Hi, I see you. Can you hear me?
Yes, I can hear you. I have a few minutes because I have to prep for the prevention strategy work group meeting.
All right, I don't have you on the owl.
Okay.
On. The owl is on, but I only hear you from my computer.
Okay. So I think if you go to the mute button and you hit that little up arrow.
There it is, owl. Got it.
All
right.
Testing. Do you hear me now?
There you go.
Hello, hello. Hello, hello. Good afternoon. I see the owl.
All right, I'm gonna pull up the screen share document.
Okay, I'm seeing it. And also your you have blur background on for your video. So I know you're prepping, but you might have to take it off so people can see everyone.
How's that now?
It's good. Perfect.
You can see the shared screen, you can see me, all that good stuff.
Yes, it's in presenter mode. I'm not seeing any other slides. I'm just seeing the one slide. So
All right.
looks great.
Thank you.
Yeah.
I will stop sharing. I think I paused the recording, but it doesn't matter. We can edit it.
Okay, good afternoon again. I was saying, okay, I don't even like potato chips. But beggars can't be choosers, not great. And my mother would be horrified to see this. I'm gonna lick my fingers and then we'll get started. Get the salt off.
Department of Health is horrified.
Yeah. Good afternoon, everyone. Welcome. I really do appreciate that you all came from somewhere and you got in your vehicles or you walked or you rode a bike and you still walked in the building despite how beautiful it is outside. So pleasure to be with you. And we do have a full agenda, so I'm going to dive right in. I'm Carrie Bridges-Feliz, of course, chair of the Opioid Settlement Advisory Committee. I'll change it up and we'll start with Dennis and work left to right, and I'll ask the committee members to introduce themselves.
Good morning, everybody. Dennis Baylor. I am community expert representative, program director at Project Web Renewal.
Good afternoon, Philip Chan, Rhode Island Department of Health.
Kate Michaud, town manager in Warren, representing Bristol County.
Good afternoon, Matt Moynihan. I'm the chief of police in South Keystone and representing Washington.
I'm Bob Bowling with the town of East Greenwich, and I'm representing Kent.
Good afternoon, this is the PA director for Comprehensive Treatment Center in North Summit.
Deputy Speaker Hall, representing the House of Representatives.
Senator Josh Miller representing the Senate.
Rachel Farrar, designate for City of Providence.
Hi, everyone, I'm Brandon Marshall. I'm a professor at Brown and an expert advisor.
Good afternoon, I'm Julie Hamel, I'm the State Court Administrator, and I am the Chief Justice's designee. Good afternoon, everyone, I'm Dee Olson, Deputy Attorney General, and I'm the Attorney General's designee.
Thank you for the introductions, and it occurs to me that we're not screen sharing. So let me look over into that.
Great.
So we are. Yeah.
Like that.
It was like it tells now.
No, we need you.
It's, Right.
Thank you.
Sure. Yeah, well, the looking at.
Okay, thank you for the brief pause. We have a number of presentations that we're going to do today. From experts to bring us up to speed. Now, I know that there are differing levels of expertise among the committee members and among the interested parties listening in. But we're trying to level set today and bring everyone up to speed to share a common base of understanding around the current state of treatment opportunities in the state and programs and efforts. So we'll have a number of presentations. We will take brief Q&A after each presentation. I don't expect everyone to wait, all the committee members to wait an hour to remember your questions. And I will do my best to manage the time to make sure that we do cover everything that we have to get through. We have several updates in addition, including a special update from the Department of Health to tell us briefly about some of the about surveillance work and epidemiology work going on at the health department to support overall opioid management efforts. And that will be helpful in preparation for our November 30th rescheduled meeting. So November and December meetings combined to one meeting, November 30th. When we hope to go a little bit more into evaluation expectations. So let's go. Actually, before I hand it over to Marty, though, the minutes from the last meeting were shared with the committee. Hopefully you've had a chance to look over any corrections or edits to the minutes. Not hearing any, is there a motion from a committee member to accept the minutes of our last meeting on August 24th? Thank you, Dee. Second?
Second.
Thank you. Any comment, discussion? Motion made and seconded, all in favor, signify by saying aye. Aye. Any opposed? Minutes accepted, thank you. And now I will invite Marty to provide an update on procurement.
Thank you, good to see everybody. I want to call your attention to the opioid settlement funded project overview that was sent out on Monday. You received it, you have copies of it, folks in the room have copies of it as well. I think that we may have settled on a format for this ongoing update, better than the slides that, just sort of change every time, but this will be our update. I want to show you, this is the combined division of the dollars for FY23 and FY24, because now all of the FY23 dollars have moved forward that are unspent into FY24. Here is the budget that we are working on. And as we've noted in here, we have encumbered approximately $18 million so far by creating more than 60 contracts, grants, or MOUs. The spending as of the 15th of October was 4.6 million. Of course, the money is out, but the agencies have to do their work before they can draw down and we can send them the money. And so you have this. I'm happy to answer any questions. I'll just say there are a couple of other things just to add. We are, or to lift up, as noted, we're working with the Rhode Island Foundation to move forward on 3 additional grant programs. You know that we've done 2 grant programs already, the nonprofit capacity building and the community-based prevention. And the 3 others, you know that these were things that were sort of on our FY23 list. We're excited to be moving forward with the trauma supports for peers and first responders, the recovery supports, additional recovery supports, and family supports. The last one being incredibly important to really support families who have someone who is using drugs or is in recovery or is in treatment. So those projects will allow for some good creativity, and we're working closely with the foundation to make that happen. We're just about to sign that MOU. And then I will happily answer any other questions that you have on the admittedly large amount of information, which we're happy about in this document.
Marta, it's less of a question, it's more of a suggestion. Could we arrange for the Rhode Island Foundation to come in on future meeting, provide a presentation?
Absolutely.
Glenn Hilburn and others on about it.
Yeah, absolutely. We can certainly invite you. Good. And just so we also know, the state folks participated in the review, so it's not just the foundation, there were state folks as well at the table in the review. But yes.
We talked about evaluation and maybe having some funded programs present for us. I think it would be good, and understanding we're just still starting to push out money. But it may be good to look at what programs now have been funded maybe for a year and then consider, scheduling that maybe to present there.
We're starting today. You'll have info today from some funded programs, and yes, absolutely, it is our plan to do that. In fact, on the months where you're not making decisions, we definitely want you to hear from the working programs.
So, question, Maria, we're gonna be talking about the FY25 procurements that were endorsed last month. Where are those? Like, are we still waiting for the secretary's letter or?
We're actually revisiting that at our next meeting.
Okay.
Because as you'll recall, the committee, approved, I'm gonna call it a framework for
Yeah.
allocating the FY25 spend. And we're gonna revisit that because you'll recall we said we each week this as we learn more information before the budget is submitted to the general assembly. So that is the opportunity next month. So we will spend time on it. Okay, thank you, Marty. Okay, so as I said, we have a number of presentations and I want to invite Linda to come on up. Linda Mahoney is the State Opioid Treatment Authority. And Linda has been kind enough to accept the invitation to provide an overview presentation. We have between Linda Mahoney, Linda Hurley, Dr. Gottfried, we have several presenters. Linda will introduce the presenters after her. And I will facilitate Q&A, as I said, at the end of each presentation. So if it's hold, unless they invite, questions during your presentation, just hold till the end of each presentation, and we'll have some time for Q&A. After all of the presentations, we will have public comment. Linda.
Thank you.
Welcome.
Thank you, Terry. Thank you to the settlement committee for having us. They have level set it on what treatment looks like in Rhode Island. I think that's a really important piece. Go to the first slide. Thank you. So the importance of treatment is understanding that this is the convalescent period. I don't know if the word convalescent is where you recover from any illnesses or diseases that you have. And it's a time that you need to go into treatment and you need to regroup and you need to find your place and answer lots of questions, get a plan in place and you can move forward. We have lots of different types of treatments and we'll go through them today, but it really is, convalescence means healing, and it also means gaining some strength. I ran a detox in a residential facility for close to 25 years, and I kept this in my office 25 years. And I used to tell people there is no magic wand to treatment, right? A lot of people go into treatment and some people do really well. Some people go into treatment and they don't do well. And actually in the first 90 days, it's a 40 to 60% chance that people could relapse during that time. So it's very, very important that we work on retention when we get someone into treatment, holding them into treatment, keeping them into treatment through each level of care. Next slide. So this is a PET scan, which is an imaging test, and the red colors really show you the activity in the brain, how someone's brain is reacting, or at the moment. The first one is healthy brain, which I think my brain's going crazy right now. So this is the healthy person on the first slide. Dr. Michael Miller is past president of ASAN, which I'm sure Dr. Gafford is very familiar with, right? At its core, addiction isn't a social problem, it's a moral problem. It's not a criminal problem. It's a brain problem whose behaviors manifest in all areas. The second one is someone who has been abstinent for 1 month. And you can see that the brain isn't healed by any means. It hasn't gone through that full convalescent period. That's why treatment short term works for some, but doesn't work for others. And they really need that full continuum of care. I really want this to impose on this on the committee. So this continuum of care, conversation, because we look for you as messengers to talk to people when they come out and say, well, that treatment facility didn't work, or I went to go visit that person and that didn't work. It's a continuum, and it's many people use for a long period of time when they have medical illnesses and they have mental health issues, and all of this is unraveled. Next slide. So substance abuse in this slide says it is a medical condition. It is treatable, and it's crucial that people understand that this treatable means that you get into treatment as soon as you possibly can, not wait longer. Like any disease that you deal with, the harder it is to really heal. Next slide. This is the continuum of care, and this came from the National Governors Association. I thank you, Kathy, for helping in this. So the foundation piece means that someone to really find recovery and get into treatment and do well is if they have supports. They have a house, they have people over their head, they have food to eat when they leave, right? All of these things are important, their medical well-being, even their dental well-being, to be honest with you. All of this is the foundation of the continuum of care. This is a spectrum of services, and what I'm trying to emphasize here is that individuals who are working in prevention, individuals like Dennis who are working in outreach, harm reduction, all need to focus on A, keeping people safe and getting somebody into treatment. It's one thing to get housed, but we also need to get people into treatment, right? So that was the purpose of this one primarily. Next slide. So this is the American Society of Addiction Medicine has different levels of treatment. And most people just know residential, right? They think you need to go into detox, the magic wand comes out, maybe a little residential, or you stay in residential for 40 years and then you're fine, right? None of that happens. What we're looking for in the ASAM criteria is the least restrictive. If someone's able to work, we want them to work. If they're able to live at home, we want them to live at home. They can get treatment 3 hours a day. They can get treatment 5 hours a day. Residential is the more restrictive, and it keeps people out of their jobs. And so there's different levels of care. I want to just point out this little red line that I put in. The committee has done wonderful things to help us increase residential. Behind you, you'll meet them later, are some of our residential facility representatives that have expanded our beds. We're doing well there. Where we're not doing well is where this red line is, partial hospitalization. This is where people can go to treatment during the day, maybe go to recovery house at night, or maybe go home and repair their family issues that they need to do. So this is our focus going forward. Next slide. So in the event that you need this information, I put this in. And I wanted to point out, since Dr. Alexander Scott was around back in the day, this has been our focus. The mantra, addiction is a disease. Treatment is available. Recovery is possible, right? These are the messages that need to kind of get out to get people into treatment. They call 988 right now. They don't even have to call 411. Next slide. So this goes in a way where people can go up or they can go down. I put this slide in there for your own information about what it is. So if something is a day treatment, it's 6 hours a day. If it's intensive outpatient, it's 3 hours a day. And if it's residential, there's a pre-authorization that determines how long someone needs to be there. And that's based on medical necessity, right? But there are other things people can do. Medication assisted treatment, which Linda will talk about later on, which is an important piece because you have 15,182 people who received substance abuse treatment in the state last year. Out of that 15,000, 6,200 were in a medication assisted treatment. And that's just methadone. So I don't have the numbers for buprenorphine, but that means that there's a percentage of people that went into IOP or A treatment. And next slide, please. Thank you. These are our slides. I just wanted to give you an idea of what we have. We've licensed these organizations If you ever want more information, go to Get Help Prevent Overdose RI. We have 93 outpatient programs. We have, just for the sake of intensive outpatient for our opiate treatment programs, we have 5 agencies and 17 locations. The reason why I say that is, since I do like the national work with the SOTA, the State Opiate Treatment Authority, I know states that don't have one opiate treatment program. Montana doesn't have one methadone clinic, not one. We have 17 locations. So we're healthy. We've always been healthy about being ahead of the curve. For residential, we have 318 beds. Thank you. We just added 70. Appreciate everybody out there. So you can see we're in dire straits before. The other pieces of concern is we only have 16 adolescent beds. 16. We need work there because that 16 is through Bradley Hospital. It's really a step down unit for the kids who have co-occurring disorder. We really need to get back to the adolescent program and have to treat adolescents differently than we do treat adults. I just want to point out, Hope Initiative is a contract that we have that goes out and helps parents and families after an overdose. We had several 15-year-olds that overdosed this week, and they were there, and they were out there. We're trying to find a place to bring them to the next level of care, is where we're in dire straits right now. Next. So what is quality treatment? I want the committee to know that we have a quality treatment. And I'm proud of the treatment that we have in the state. You might hear about the problems, because I do. As a matter of fact, if there's ever a problem, people can call the VHPA hotline. We look into grievances of abuse, neglect, financial exploitation. If there's a problem, we go out and review it. So the 5 signs of quality treatment is there's a good inspection record. Every agency is inspected by our department, the HDBH, once every 2 years. We have stopped admissions. We have given people provisional licenses until they come up to par where they need to be. So we're on it, just so you know. They have to offer FDA approved medications. And not only do they have to provide evidence-based practices, but they have to talk about the risk of returning to drug use, harm reduction. Family members, if it's a good program, are embedded in our system. We're not there yet, but we might be there very shortly. Part of the settlement dollars is to support that process of embedding licensed marriage and family therapists in our facilities. So they meet the family when they drop off their child, their adult, their partner, whoever it might be, and that family member gets treatment right there and then. That's through the, I can't go any further, sorry. The next one is that convalescence period, that continuum of care. How very, very important it is to have recovery houses, employment services, 12-step meetings. There are people who maintain recovery and never walk into treatment. They've done it through 12 steps. They've done it through their church. We have the Amani Project, which is faith-based. It's embedded in communities that have not been found Hispanic, African-American communities, that people are not coming into our residential treatment. We're going to them. We're bringing mobile treatment. We're bringing faith-based community services. You ever want to know what it's like for the first day of going into treatment? You can Google that. First day of the fun. Thanks. So the treatment work group, what do? We try to maximize graded fundings. I'm the PI for SOAR grant, which is the State Opiate Response Grant. We make sure that what the SOAR grant won't pay for, maybe the settlement will. So SOAR grant has never allowed us to pay for construction. Settlement dollars has allowed us to add construction. It's finding out which ones, as the state substance abuse authority, the HDH, we know the treatment, we know what we can do and what we can't do. Build partnerships. We're working with the Hispanic community to make sure that they know their resources and to build that resources up. All of these and substance abuse, stimulant use disorder treatment conference is coming up. We're hoping you're all going to be part of that. I'm very, very excited. I'm looking for keynote speakers, so really go find me somebody. And we're looking to advance adolescent substance abuse treatment. Next. I like to leave on a hopeful note. There's an acronym in the 12-step programs that's for hope. It says hold on, the pain will end. I'd like to believe that this opiate crisis gonna end someday soon, so I can be tired. But, we get White House messages at the department all the time. Linda and I have met Dr. Cooper at the HI conferences. In April, he said, as long as we have more drugs coming into the United States than we have treatment beds, we will never win this war on drugs. We now have more treatment beds than we had in April. Thank you. In August, he said, provisional drug death data shows a flattening of drug overdose deaths. That's nationally. We had a flattening, small amount, I'm believing for this year as well. After this week, wasn't so good. But believing week by week we get better. And finally, this one came out, the impacts on impacts are being made by sanctioning the Sinaloa cartel, the primary suppliers of fentanyl coming into this country. That's good news. So that's a level set of where we are, and if you have any questions, I'll take them. If not, I'll introduce our next case.
Questions from the committee? Or
Yes. Committee members? Please stay.
And so that was a terrific presentation. So first of all, thank you. I thought it was excellent. The slide where you really highlighted the need for additional adolescent beds, you had a lot of data on that particular slide. I think there were like 2 detox programs. I just wanted to ask you, based on your knowledge, are there needs? So the adolescent beds clearly a need. Are there other needs particular there? Do we have enough detox? Can people get in if they want to get into detox today, tomorrow? Can they get in?
Today, so we have a meeting every Wednesday. We have the detox residential peers, residential facilities. Everyone comes together, HIDA, Fusion, Rido, everybody comes in to talk about this week's overdoses. This week, we have an open bed as in there. So we let the community know when there's an open bed and when there's not. Generally, detoxes fill up kind of quick, but we also have Butler has detoxes and Roger Williams has detox. These are licensed facilities, right? On the residential side, there's a wait list. When before I got the expansion, the wait list was 86 people waiting. And we'll talk a little bit about that. We still need more residential facilities. I just want to give you the numbers really quick, because you brought it up. So I said there was 15,000, right, for people in treatment. 32% of them are women, the rest are male. So our male facilities, you'll see interviewing people that are behind you, are being expanded. And the next step is to expand the female facilities.
Do you know what the wait list is now?
So it depends. So some of these expansions have opened already. Some of them are in process of opening, so they're still not where they need to be. I didn't check them this morning. I think on Monday it was like 62. But the people waiting on that waiting list is problem. That's where we lose people. Yes, sir.
First, thank you. Appreciate that. The thing about the beds, the 48 female beds, and then we had just brought these out. Do we know when we're gonna see any additional female beds come available to the community? That's a small number.
The next step. So then the next step is to put out an RFP asking for more female residential services. That's in process right now. And some of the newer beds that were expansion are co-ed. So we picked up, so Eastman House had 5 people in it when they closed. We picked up 8 in the co-ed services. So we're kind of balanced right now, but we still need more.
And 13 residential locations, I can't think of 13 locations.
I can tell you every single one.
But is there some place where we can see?
Yeah.
These,
Absolutely. And one of the slides, you go back, you'll see the residential, it's the phone numbers on how to contact people. I believe they're all there.
Okay.
And it's also on Prevent Overdose RI. One of find treatment. This one here is located in your community. So if you live in Providence, and if somebody wants to stay there, you can go there. But if you want to go outside that, really Prevent Overdose RI, find treatment or get help, has a listing of all the residentials by area. So nice, pretty graph you made, or your max day for us. Thank you. Anything else? Yes, sir.
I assume that
a large percentage of the patients seeking treatment are Medicaid patients?
I would say, yes, we only have like 2% of our population that are that have no insurance, or 2.4. And we have funding for the uninsured in medication assisted treatment as well as residential, as well as detox,
So a large percentage are
Medicaid.
paid by Medicaid. So, and I assume that one of the issues in expanding services is workforce related.
It's better now than it was, I would even say 6 months ago, and I'll let the CEOs talk to that. We know we're still struggling for nurses, but everyone's struggling for nurses. Workforce is always an issue because, but I have to tell you, people who come work in this field love it. They either love it or they jump, one or the other. But the people who work in this field, the rewards are amazing. I walk down the street and I still see people that, come up to me and remember me on it.
So the next part of that is there were recently recommended rate increases that OHIC recommended. And I assume that would have a positive impact on the whole continuum of care if it was implemented.
It would save it from sinking.
Right, and so how urgent,
Well, we lost Phoenix House because of that. I'm
Right.
pretty sure I lost Eastman House because of the rates. And the people that are sitting behind you are sticking through because there's been promises made that it's coming.
Yeah.
But I've also made that promise 2 years ago.
so it's an urgent,
It's urgent.
right,
Thank you for bringing that up.
probably more urgent than spreading it out over 2 or 3 years.
I can't even imagine who we lose next. We're building beds, but at the same time, if we're losing it, it defeats the purpose. And it's really hard to put an RFP out there to ask people to come in when they know the rates are not sustainable. So it's a catch-22. If I have the rates, I'm gonna try to get more responsive to my RFP. So, thank you.
Yeah. So if it's a sector you care about, you want the rates to be as quick as possible.
Quick as possible.
Rather than over 2 years.
Absolutely. Because we have been the stepchild for a really long time in getting any rates. Substance abuse is always somehow or another, parity is not always there, to be honest with you. We're working on it, but that's where the rate recommendation came from, a parity review. We are not getting the rates we really need to get.
Thank you, Linda.
Yes.
I'm not gonna answer your question, Linda, because Linda's about to introduce Linda, to come up and present.
I want a quick thing before, just to note on the workforce issues, and it's something I neglected to say before, which is that beyond the settlement dollars, EOHHS has just allocated $6.6 million to the substance use disorder workforce, 3.3 to OTPs, overdose treatment providers, and 3.3 or 3.33 each to residential for recruitment and retention of employees. So besides the settlement, EOHHS wanted to, this is through home and community-based services dollars, HCBS dollars, knew it was important and wanted to make sure that we were investing there. You would also probably be interested to know that there were an additional 3.3, so for a total of 10 billion to mental health, MHPRR, so mental health residential services. So, wanted to add on to the settlement dollars wherever we could.
Yeah, because we had people who didn't want to work an opiate treatment program. You have a clinic, you're dosing people every single day. Nurses were catching COVID, bringing it home to their families. They were not getting the acclimates that you would get from nurses that were in hospitals or nursing homes, but they were at their station every single day. And they really deserve that. I want to introduce Linda Hurley, and I'm going to surprise you right now. So Linda Hurley is president of Kodak and the CEO, and generally has reached and received many awards through the state. I'm going to announce to her right now that I'm going to nominate her for the Wanda Dole Award from the ACOG organization in the state of Connecticut.
That was something to a curveball.
Well, my goodness, thank you. You're welcome. Thank you. Yeah, that was perfect. And what my goodness, so what I was about to say, and so I'm just gonna say it really quickly and just thank you again. That, you know, the HCBS dollars that came to us slowed down attrition. I mean, I couldn't imagine how, I can't even tell you how much it slowed it down. I told you that before privately, but this is a wonderful thing that EOHHS and DHCDH managed to do with these dollars, and all of us are forever grateful. So, because it is absolutely amazing how our numbers have started to stabilize. And just quickly to speak to Senator's question here, is that there are three things wrong, and I'm saying wrong, with the budget recommendations. One is that there can be could be a 2-year wait for an increase, and we don't really know if it's even going to be 16%. And then we also asked for COLA increases, like cost of living increases, like hospitals and other places get. And that was refused. It did not go into the recommendation. I don't know why people think that behavioral health care and the individuals that, you know, work for us and the people that come to us for care are treated so beautifully, don't need a new car, don't need to buy a house, don't need to have kids, don't need to, it's remarkable. So the COLA has been refused. And then the last thing that is very wrong is that they said, well, we're just going to review behavioral health rates every 2 years. Doesn't say what's going to happen with the review. And this is the first review that I've seen in the last 15 years that's anywhere near even decent. So for behavioral health. So I'm just putting it out there, and if anybody wants to talk about it. I'm always happy to talk to you. Okay.
And then can I just add, Linda's referring to recommendations that came out of the Office of the Health Insurance Commissioner, which is from OHIC, just to clarify.
Well, it
Folks
moved,
aren't familiar.
yeah, it came from OHIC and then, but they were incorporated into the governor's
EOHS
UHS budget that would go to the governor, that went to the governor.
which is not settlement dollars. We don't.
No,
have
no.
control.
I'm
Which
sorry,
we did.
I just had the floor for a minute. I get it. Okay, so I am representing, OTARI, which is the Opioid Treatment Association of Rhode Island. And I'm going to go quickly. In your packet, you will find that, you have an understanding of who OTARI is. And we really, the most important thing for everyone to know is that the Opioid Treatment Association of Rhode Island is a wealth of competence. We have ASAM docs that are trained in opioid treatment. We have clinicians and psychiatrists and therapists and peers and all kinds of folks, all categories of treatment providers and service providers that have a depth of experience. And so we are a really good spot. If you have any questions, you can reach out to OTARI, and we're rebuilding as we speak. COVID took us apart. We lost our website, we lost a lot of things, so we're rebuilding. But my number's on my email is on the back of this presentation. So if you have any questions or you want to have any help at all in understanding the disease, I'm happy to talk to you or refer you to someone that is going to be able to meet your needs. You have, we took just webpage information, but I wanted you all to be able to see who the individual groups are, so we can move on. I'm sorry. So we can move on here and just go through those. You can read them at your leisure. You can look them up, but at least you have the total names, the full names, and you can reach out in the various communities. We have a tremendous penetration in the state, like Linda Mahoney was talking about. So I'm going to talk, let's keep going, please, and come to a picture, I believe, because this is the most important thing. I was going to do a little bit more and I'm gonna be really good about 10 minutes, so I took some slides out. We're having a lot of political, and it really is nonsense right now, on the national level, not so much in the state, but on the national level. And there is some real vilification, there's attacking on methadone as a medicine. So what I'm just asking you to do, because it proliferates, it comes down in all different ways that, you know, it hits our patients and our staff. And they should be so proud of what they're doing. And this is the kind of language that's coming down from different legislation, et cetera, that is really, it's the worst phase of stigma, because it's coming from a place of perceived competence. And it really, really impacts treatment. So, this is a way that I have been teaching for a long time. And this is a way that I taught, chronic up and relapsing disease, brain disease, to prosecutors, judges, students. And, it's just to understand the disease, because if you understand the disease, then you can understand why all three medications are so important to be offered in the treatment of opioid use disorder if someone chooses to utilize methadone. So the first time someone uses, you know, I don't know, I'm in college, I go to a party on Saturday night, I use, and it feels good, okay? I like it, okay? I wake up the next morning, tide goes in, tide goes out, another 24 hours. There's no footprint in my brain. I just remember that I probably liked it. But, you know, the consequence, I've heard enough, fine, I tried it, done. Over here, you have a goat path. The goat path, now I said I liked it and I want to do it again. Okay. So now there's a pathway in the brain that's starting to develop. It says, this is what I need to feel good because I like it. So there is a foundation, right? Now we get down to, I want it, okay? There's the two-lane kind of country highway there. And that is when the real component of the disease clicks. The switch is hit, and back here in the back of the brain, the survival brain is, I really want this. And I actually think I probably need it because it's the only thing that makes me feel good now. Over here, you got 7 lanes in Las Vegas, you know, and this is, I have to have it for survival. So the survival brain is saying this has to happen. The important piece of this is it's a visual demonstration of the progression of the disease. And if you understand this, say I liked it and I used it 3 times. Maybe it was alcohol, I got a DWI and I was, oh, consequence, yeah. And maybe I need to go visit Aunt Millie in Texas and get out from the crowd that I'm hanging with. But there's no real brain change yet. Here, you could do some serious change, some recovery supports, all that, you know, is good. You might, maybe buprenorphine products would work for you here. You know, if other activities or other choices you're making for your recovery from this aren't working for you. Here, now you're looking at just how deep is this, where have I moved from want to need and have to survive. And that's where either a buprenorphine product or a methadone product, if somebody was choosing to use a medicine, would come in. And here, what do you think this one is? 80% of the people that have this change request methadone. 80 some percent, I can't remember the exact number. So can you see then why all 3 medicines are important to offer? Does that make sense, Brandon?
Yeah.
I'm sorry, Doctor.
Yeah.
That was rude. Okay. So this is what it's important to say. All 3 medicines, you know, they're all FDA approved. There's all different ways that you can administer them. And if it's based on individual clinical need, all 3 can be effective, but all 3 will not be effective at the same stage. does that, I really want you to understand it. Do you guys know it? Okay, next, please. So methadone, it's called, it's a full replacement, you know, so people often will say, oh, you're just replacing one drug with another. We absolutely are, that's why it works, okay? So nothing bad about that, nothing bad about that at all. And this just shows the receptor, and I know you guys know about that. And here the methadone fits in just like the naturally occurring endorphin would fit. Next one. Buprenorphine is a partial. That, it's nice and sticky too. But the difference is that buprenorphine has a sealing effect. And there's been a lot, I know that you've talked before about buprenorphine here. It's low threshold, it's a wonderful medication, and it works for many, many people. It just does not work for all people. Next one. Naltrexone just blocks everything. So how we found that naltrexone really works is either in the early stages, because if I use now, if naltrexone is blocked, if I use now, I'm not going to enjoy whatever it is, or I'm not going to get the relief that I need to get if I've taken naltrexone. So early on, or in recovery. If somebody's already started to walk into their recovery and they're feeling stressed, something's cooking, they're nervous about their remaining abstinent from the substance that they're going to use, then this is a really good thing to do. But about less than 1% of the people that come to us for care, and that's about 5,000 people or families a year, less than 1% elect for naltrexone. And usually it's because they're already in recovery and they feel like that something is causing tension in that. Next, please. Okay, simple as this. Stops withdrawal, doesn't produce euphoria at the right dose, gives the brain an opportunity to heal. That doesn't mean that you build the same road back again. It means that you take time to build new pathways. Brain is very cool at that. Next. Did I do something?
I think Marty did.
No, sorry. I already say that to you. Marty did it. All right, this is important and we're almost done. I think I'm good. Okay, thank you. Whew. So in an opioid treatment program, and all of them, CTC, ARI, VICTA, now I'm gonna do that thing where I forget somebody, you know, I put them all in here so everybody knows they're there. Most of us treat all substance abuse disorders, not just opioid use disorder, okay? We have specialized care for opioid use disorder. And we have provided all of the medicines that I talked about. And through, this is important, either through direct provision or referral. Psychiatric care, behavioral health care, primary care, health home services, which this is tremendously important. And Linda Mahoney and with Director Boss at the time invited a bunch of us to participate in creating a health home project that you ultimately got approval for from CMS. All social determinants for a predisposition for this disease are there in an opioid treatment program for somebody to actualize. It's wonderful, you know. Now, again, remembering that, like Kodak, for example, because I know Kodak, we treat infectious disease, but we also refer for other things as well. Reproductive health care, care for aging, access housing, food stability. We just say them because they're so important. Employment, career path development. And then there is just consistent services for all medical care and referral. Next, please. We also have centers of excellence. Centers of excellence Linda Mahoney had talked about how important the initiation stage or the induction stage, the early stages of recovery are, you know, the first 90 days. So the Center of Excellence is, well, we are all centers of excellence in an OTP in Rhode Island. So it's like the hub and spoke model, you're familiar with it? And that means that a primary care doc, you know, your son, your daughter, your husband, your wife, comes and says to you, I have to tell you, I'm in trouble. I'm in trouble. So you go to your primary care doc, and the primary care doc says, well, you can go to, ARI, this person who came to my head. And and the family hopefully gets treated, you get treated, you can be there daily if you need to be. All the pieces that come together that would hold a foundation of recovery are going to be provided to you. And when you feel strong enough in your recovery, you just go back to your primary care doctor. Just center of buprenorphine programs. And if something happens, you lose your job, I don't know, anything bad could happen that could shake you emotionally and you feel like you need more, then you just come back into the center of excellence. And when you feel stable again, that's the term that's used. When you feel safe again, you can come right back to your primary care doctor. This is very important. And I found this to be across the board. I've asked questions of all of the OTARI members in Rhode Island relative to EDI and culturally congruent staffing, and we are all right there. I feel really good about that. So next, thank you. All right, myths, and we're done. Okay. Daily dosing, people have to come every day. They do not have to come every day. 100%, and I only got I asked the information of others, but they didn't get it to me in time. So I'm not representing Kodak, I'm just using Kodak as an example right now. 100% of our patients have at least one take home. 100%. And that just means you take home your medicine to self-administer it. Okay. So, and I think I have the numbers coming up just because I wanted you to see that in the old days, back in the day, 15 years ago, that was real. It's not real now, and we're working even harder in the treatment group to come to consensus across all the opioid treatment programs to match the federal regulations, which are very relaxed. And this part is important, so I might skip some of this. But during and I'm going to tell you that I can't remember your new title. Chief.
Call me Matt.
Okay. I was captain. It's not captain, and it's anything.
Call me whatever.
Chief, well, two things are called Chief Moynihan and the Hope Initiative. This is just a nice thing. Have recently partnered with Kodak, so we're really excited to do that. But during COVID, when we put out just under 300% more take homes or medicines for self-administration, when we put that out, I sent letters to all the police chiefs, the city managers, and the police and mayors, and said, this is going to be what's happening. Please call us if you have any problem. Please write to us, do whatever you need to do. And also got were thank you notes back for 2 years. I never got a complaint. And then chief. The chief, that's what I'll do now. The chief got me information at that time through the Rhode Island Police Department and State Police Department. We had no increase in found medicines, no increase in confiscated medicines, and no increase in methadone-related death. Now, other states haven't had that. They haven't had that experience, but we had that experience. Linda, you took it on VCP, right? Mm-hmm. Yep. So this take-home piece and the idea that you have to stand in line in long lines. If anybody wants to look on a webpage, you can see many of us have small sites with only 300 people that come across the course of a month. This is old thinking, and it's stigmatizing thinking. And a lot of people don't want to withdraw from the medicine because it makes them feel safe and it doesn't make them feel sick. Rockefeller University, Mary Jean Creek, one of my idols, did a study, and she tested people who were in opioid treatment for 10 years. And what they looked at were 7 different systems, cardiac system, hepatic system, renal system. And everybody actually became healthier. And a lot of, so there's a lot of mythology. There just is so much mythology. You gain weight, you probably can gain some weight, but you're also eating for the first time in a long time and not just driving around trying to get to Broad Street or trying to get to New Bedford to get something and worrying about where your kids are, that kind of thing. Newport did a study, it was Chief Weaver at the time, and crime rate went down when we moved in on Thames Street. And he did it for a whole year. It's pretty cool. You don't have to be on it for life. We're doing a whole lot of things, utilizing buprenorphine to step down to not have to be on meds anymore. This is absolutely, and I just heard this on a community forum. This absolutely is not true. We don't kick anybody off. And the HDDH helps, so this office helps. No one gets kicked off of a program. They only get kicked off a program if their presence there becomes a true safety issue. This is old. And of course, rotting your teeth, that's so silly. People often have not spent a lot of time on dental hygiene while they were continuing to use. And they will see the repercussions of that. And then that's where that came from. Just need to rinse the nozzle. And destroying your bones is another one that it's when people are so afraid of being on the medicine that they want to go down, and they go down too far and they're like in this kind of partial withdrawal and they live in it all the time. There you go. Next one, and I think we're good. Yeah, this, you can just skip this one. This was what we were saying. Bottom line is everybody has something. Because you can go. And then that's it. I summed it up. Whew. I think I did it. Anybody have any questions? Can I ask? No? They said it all? Okay. You good? All right. Thank you. No. Oh. All right, so our next speaker is David Gaffney. So the point that I was trying to make earlier was about retention, and we brought him in. He is from Dynamic Care. He's an addiction psychiatrist at Harvard. He directed the Mass General Addictions Research page. He has over 150 publications from ASAM, the American Society of Addiction Medicine. I am truly one of his biggest fans, and so grateful that he's doing contingency management in the state of Rhode Island. Correct, Jeff?
Thank you. And the feeling is mutual. And if you've worked with Linda, you'll know why I say that. First of all, congratulations. You're the first in the nation to do a project like this. Thanks to Linda's vision, you've actually set a new model for rating funding from federal dollars that are politically inhibited from using evidence-based science for the funding of addiction treatment, and they can't fix it because of the circumstances in our House of Representatives. But Rhode Island figured out the solution, and I have presented that solution to Dr. Rahulga, our drug czar, who literally listened, and he gave me 2 words back, and he said, "Bless you." Because we figured out here at Rhode Island how to deliver this approach. So what is the approach? You go to the next slide. Thank you. You just heard Linda talk about the medications that stabilize the receptor. That's a molecule effect. You also heard Linda talk about the pathways, the circuitry from those molecules to the brain that controls behavior. But there's an in-between step that you need to realize, and that is the cortex, the big outer gray matter of the brain, is where we do our thinking, our learning, our decision making. But what drives the cortex to motivate, to do decision making, is a chemically controlled region of the brain called the drive system or the reward system or the limbic system, okay? This region is where dopamine, the reward neurotransmitter, is secreted. And it's secreted when all of these drugs of abuse, heroin, fentanyl, methamphetamine, cocaine, whenever those hit this region, because they come through the bloodstream, right? That receptor effect is to release dopamine. And that dopamine tells the cortex to get more of that to happen, okay? So it's driving behavior, and over time, it reinforces behavior, meaning it sets up those growth rates that you just saw. So that's absolutely accurate metaphor for what's happening. But if we only stabilize the chemical receptor, and we only talk to the brain and talk therapies, we're fighting this disease with one hand tied behind our back. We're not dealing with the motivational system that drives the behavior change. And nobody in the country has really been using an approach that is proven to work on the motivational system. So if we go to the next slide, I'm going to explain what that approach is. It's called contingency management. You manage behavior with contingencies, rewards and sanctions, carrot and stick. Contingency management, there's another name for it, motivational incentives. You're incentivizing people to become more motivated. Because when Linda in the first presentation showed you that brain slide and those little red sparks in the middle weren't lighting up, that's not working in early recovery. And so people don't have the dopamine secretion. So their brain is literally starved for reward, pleasure, excitement, positivity, hope. And so they wake up every morning and they're walking on eggshells thinking, today's the day I screw up again. Okay? If we could give them rewards to stimulate their interest in doing healthy behaviors frequently, easily, on a fast basis, we would be substituting that instant gratification for drugs with instant gratification for healthy behaviors. And then we would be changing those behaviors. So this contingency management actually has 100 different studies published in the scientific literature. In any other branch of healthcare, oncology, cardiology, hepatology, if you said we have 100 studies proving this works and it works better than anything else, nobody would say, well, I want to see the 101st study, okay? But we tend to do that in this field. So it's not a lot of money that's required to stimulate the brain's attention to think about, well, what's the healthy behavior they want me to do that I could do easily, that I would get $1 for or $2 for? It only requires about $100 a month, and only for about 6 months. And this is study after study has shown us. Medicaid will even pay for this. This is approved. It's approved by the Office of the Inspector General in Washington, D.C. So we have the ability to do this, and it's endorsed by the Surgeon General, the NIH, ASAM. In the next slide, you'll see the National Drug Control Strategy out of the White House for 2 years has been calling for providers and systems all over the country to introduce this. And Rhode Island is actually leading the nation in this. And they call for an approach that's very specific, using smartphone and smart debit card technology. Why? Because then you can do it in the moment, in the community. You don't have to travel across Providence or up from one of the remote regions of the state and go into a clinic to pee in a cup in front of a counselor. You can do this remotely and yet securely. So in the next slide, you'll see that we can do behaviors like reminding people to go to their AA meetings or NA meetings that they say they want to go to, but their lives are very chaotic. And we can send them a reminder a few hours ahead of time, right through their phone. Show them even the Google Maps directions so they can't get lost. And when they arrive, we can turn on the GPS in their phone to determine that it's the right person, they've arrived at the right place at the right time, and give them $1 for showing up at their AA or NA meetings. So we can actually promote AA fellowship-based recovery. This works with all kinds of treatments. We can ship people right to their home. We're doing this right now here in Rhode Island. Saliva test kits or breathalyzer kits that they take with them wherever they go. They go to the movies, they go out to a restaurant, they've got it in their pocket or their purse. And the phone randomly alerts them that in the next 2 hours, please do a drug test. They go into the bathroom stall, close the door in privacy. They turn on their phone's selfie camera and they do a video selfie of a saliva drug test. And then they show the camera whether they have shown up negative for all the substances that they're not supposed to be using. And if they've done that, they start out getting $3 for that successful, valid, negative drug test. We do this evenings, weekends, holidays, like no clinic can do. We can test New Year's Eve and again New Year's Day, because it's true random. And the technology is, everybody's got a smartphone. If they don't, we can actually buy them a smartphone. So the accountability is a huge advantage, but the motivation drives behavior change. And it's HIPAA compliant, it's 42 CFR compliant, it's passed all kinds of hacking testing that the federal government and public insurance companies and public funders require. We go to the next slide. We do a variety of tools, supports, and behaviors. So the patient has at least a weekly meeting in the beginning with a contingency management guide. We actually hire certified peer recovery coaches, but we train them into a new role. So they're not stepping on the toes of community-based coaches. They're doing a different project. They're actually helping the patient get the most rewards they can be entitled to. So the patient says, no, I know, I did that appointment, that's fine, you know, it's only $1. I want to get my bigger reward for drug testing. Okay, why didn't you get your reward for your drug testing? Well, I was using. Okay. What can you do to be less likely to use? We don't ask you to be perfect. What could you do to be less likely to use? Well, yeah, I missed my counselor appointment. Okay. Do you think you should talk to your counselor? That'd be helpful. Well, I could do that. And so it's measurement-based care. So we're looking at their behavioral performance data, and it's rigorous data. The guides are working on helping the patient succeed with their substance testing. We're doing appointment tracking. We're asking, should there be other health-related appointments or recovery-related appointments you should consider going to? Maybe you should start going for vocational rehab testing and education. We provide nearly 100 different topics of cognitive behavioral therapy. This is a short reading on triggers, denial, trauma, loneliness, and we pay $1. So instead of going to Facebook when the patient is bored and starting to crave and thinking, man, if I could only get high, I would feel so much better. Instead of Facebook or Twitter, they go to this app for $1. They'll spend 5 minutes reading the cognitive behavioral therapy module on boredom. And then they get in touch with those feelings. They do a little exercise on the phone, they answer some comprehension questions, and they get $1 for that. And now they're feeling that, oh, yeah, well, I know I'm bored, I didn't plan to do anything. So now they can change their behavior. We also provide evidence-based family services. There's a lot of activity here in between the Wednesday to Wednesday counseling meetings in their outpatient program, but they get to do it at home when the need hits. And the reason they do the effort is because they're getting rewards, and they get it right on a Visa debit card. Doesn't say anything about addiction or even dynamic here. It can be used almost anywhere, but it's protective from relapse. They can't use it in a bar or escort service or casino. They can't spend excessive amounts of money. We track how they spend and catch them if they're starting to slip into compulsive or impulsive spending. And we call the treatment provider here in Rhode Island to say your patient may be in need of an intervention before the relapse has to happen. Now, this is a very unique program. It's the only one in the country that has approval from the Office of the Inspector General in Washington. So there's no violation of anti-kickback laws or other laws. It's also remarkably positive in the eyes of patients. It has higher patient satisfaction ratings than the customer satisfaction ratings of Apple and Netflix, the top industry customer satisfaction companies in the country. Next slide. And we can start with people in harm reduction. The orientation and enrollment phase, when we're welcoming the patient in, doesn't require people to be absent, because many people aren't ready or cannot or won't choose to be absent, sometimes because they don't think they can. So that's okay. We can reward them for just learning to use the technology and becoming competent at doing valid drug testing. Because if they're doing the testing, they're checking in with where they're at, and they're sharing that with their treatment people. So that's a positive thing we can reward them for. We can transition people into the habit of regular testing, starting to get more abstinent, building up their skills and their habits in the anchor phase, and then transition them into a more stable period where they're expanding their resources, their family and their community. About 6 months, we transition the patient off of the financial rewards completely, because after all, those are artificial. You can't sustain that forever. But what we want to do is switch the brain's focus from instant reward for frequent, quick financial successes and into community reinforcers, like getting a job, saving up for a car or an apartment, rebuilding trust with loved ones, the long-term gratifications that the rest of us live for. And that's what it takes to have a healthy recovery. So this is a 12-month-long program, and it uses computer algorithms to transition the patient from those quick, early, instant gratification rewards to long-term gratifications. And the result of this in multiple controlled studies, including random controlled trials by external research groups, including Johns Hopkins, is a doubling in the success, doubling in the abstinence rates. In opioid use disorder patients on buprenorphine, on Medicaid in the inner city in Cincinnati, who are only getting 17% of their urines abstinent, but doubling that by adding to treatment these incentives, which increases their retention and their attendance, which helps the milieu, the culture of the clinic, the bottom line. Even the people who have co-occurring methamphetamine addiction on top of their opioid addiction, they're doing worse. They're only getting 13%, not 17% of their urines absent. But we're still more than doubling their abstinence with the incentives. In West Virginia Medicaid, they wanted to see 90 patients recruited in 12 months. We got 93 in 6 months. That's how popular this can be when it came to this. And 77% of those who downloaded the app and logged in were able to complete all of the training and become competent and master all of the testing. So it's a very well-developed, well-taught program. And they're doing frequent tests, frequent CBT modules, frequent appointments. They're not earning that $100 per month that's available to them because it's not perfect. But they're earning more than 50%. They earn 50 to 60% of the available rewards. And as a result, all of this activity is keeping progression throughout the week and across the months. This is not just clinically effective, it's cost effective. Now, buprenorphine and methadone save $4 on average for every $1 that's expended on it. Very positive return on investment. But if you're using a combination of these approaches, like we do, motivational interviewing, incentives, CBT, and the high level of incentives, you're getting 10 times the amount of return on investment from that dollar spent. So that's why insurance companies like Massachusetts Blue Cross Blue Shield covers it statewide for all of the employees. Fortune 500 companies, every Whole Foods employee in the United States gets access to this. In the last slide, now that we've started this in Rhode Island, thanks to your funding, this, in just 14 weeks, has resulted in 139 patients referred, planned for 140. In 14 weeks, we've already got 139. And 58% are succeeding in logging in already. 29 have completed all the training, and we're just getting started. So all these patients are still in process. And when we look at the retention, I suspect you're going to see what we've seen elsewhere. For instance, West Virginia, 65% were still retained in the program at 6 months. That's astoundingly good. Nationally, we're in 45 states. When you look at national data for this program, so this is at 6 months, this is close to 65%, which is also what we see in West Virginia Medicaid. At 12 months, we still have close to 50% still retained. And compare that to a gold standard FDA approved treatment, buprenorphine. This is national buprenorphine retention rate. It's 15% at 12 months. This is almost 3 times higher than that. So when you fight this disease with both hands, you're doing the medication at the receptor and the pump therapies, but you're also working in between at the circuitry to motivate change in behavior. That's how you double the success rate. And you have really launched on this in a statewide program, thanks to integrating funding from multiple sources. And if you can move this along, expand it, and convince Medicaid to put this as a treatment provider, which is what we're doing, for instance, in Virginia, then you'll have sustainability long after these funds run out. I'll stop there.
Thank you. Questions? Dennis?
Thank you for the presentation, and I can certainly see the benefits of the dynamic care services for people who are in recovery or want to get into recovery. I thank Linda for, we had discussions about stimulus users, and I'm the co-chair of the racial equity working group. How can we reach the people of color who are stimulus users to bring them into the cup of showing that we care about them, and contingency management was mentioned. I'm an ex-stimulus user. We had a discussion, I think, at our group, and putting on my co-chair hat, looking at the 139 patients who were referred, I have a sinking feeling that either you don't have the data or the numbers are very, very low for people of color, because who you're engaging with are the people who are already involved in the MAT services. There's no reaching the people who we were initially trying to get these services provided for. So again, it's great service for people who are already on medicated assisted treatment, but it falls short of something that we had asked for, which was funding for some to ensure that we get the racial equity lens, and ensure we can get the stimulus users involved. And again, it's nothing against what you're doing is going to work. I just think that it doesn't
Yeah, it will work. What you're saying is exactly right. It's not the way this launch was planned. You're also right there. And if it can be expanded to that population, people will sign up. They will sign up even though they're not ready to stop, because like rewards for just doing stuff that I can do. What's wrong with that? They will sign up, and we can reach people who aren't even attached to programs, and then we can link them to the programs through the work of our guides.
The tricky part is kind of with those people.
You can do that on the street. You can do street outreach.
Well, thank you so much for taking the time to come down. Thank you for all your work in general. Just a question on your business model. I understand that we're funding sort of a pilot for this. If a clinic wanted this, could a clinic buy into this? Like, who pays for it, and about how much would that cost?
Yeah, so actually there are clinics around the country that are paying for this out of pocket. Now, they tend to have value-based contracts where they're responsible for the overall care of the patient, and this dramatically improves the patient's attendance and treatment so they can do a better job. Payers are starting to cover this. New Jersey Blue Shield also covers this statewide. Aetna and Anthem have both done pilots funding this out of their own coverage. It's now moving from pilots into just being listed as a provider. And when we can show the result of this, we intend to show Medicaid in Rhode Island that they should be listing this as a provider and cover it. And then every program in the state that has Medicaid patients will be able to refer and use this as an adjunct to their services. It works in all the levels of care. Discharging from rehab or detox patients can be started on this before they even leave to reinforce their attendance at the step-down treatment.
So I may have misunderstood. Are you doing the actual contingency management? Do you have a person on the other end that's actually, okay, so the clinics wouldn't do that, like this platform is actually.
Yeah, that's really important. Our business model is clinics are burdened. They don't have the bandwidth. This is technical stuff. The accounting is, pennies and dollars every day changing for every single patient. Let technology take care of that stuff. So we just ask the programs to have the patient call us. And they call us and we have a certified peer recovery coach who's trained to do enrollments and educate the patient on what to expect. And we take it from there. But we provide the data back to the clinic so that if they know somebody's deteriorating, they can step in and focus on the patients who are at the greatest need.
I think the other important question is we think about this from a statewide level, and Medicaid is, what if someone doesn't have Medicaid? What if they're uninsured? And my guess is you wouldn't do them. So we would have to think about, and then it's point too about equity, how that would be addressed.
I can tell you, we put it on our 1115 waiver, so the intent is, so this money from settlement was to change systems, so, and I want you to see that that was the utmost importance, we're changing systems. We're starting with the pilot program with OTPs, but only individuals who are opiate and stimulant use disorder. From there, we're taking that 1115 waiver, which has already been approved by California. And we're following that run to make sure that this is something that has sustainability to it. Thank you.
Yes.
I love the model. I think there's potential in the is there competition?
Yes, well, there was competition. There was a program called Pair Therapeutics, which was based on very good NIH research also. Theirs was only a 12-week model. And although they raised a lot of money on the stock market, they actually went out of business in 2 years. So no, and there is no other program that has OIG approval. So we've been getting sole source contracts from states, counties, because there isn't another option. What we do, however, is spend a lot of time with people in the field, guiding us on how to configure, how to change, how to improve, so that even in the absence of competition, we are learning from the process and constantly changing to improve the algorithms.
So this is probably a question for Linda rather than yourself, but has the pilot been, have you been impressed enough on the pilot that you want it available to all Medicaid patients?
You have the greatest question. So first of all, we started the Mimic project with Brian, where we trained all our staff in our OTPs on contingency management, and it didn't take off for some reason. It just went flat. So we already had the foundation of staff trained in contingency management, but they were overburdened, as you said earlier. They couldn't do this all, right? We had little lockers set up with all gifts for people to pick from a row of lockers. It didn't work. They didn't have the time. They didn't have the time or workforce. Bringing this in is actually a relief, and in addition to our open OTPs, but we need to expand this. Absolutely. I'd like to see it in our residential program. One of the things that he didn't mention is a family member can say, I want to buy this program for my son. You can live here as long as you're involved in contingency management, and I'll see your urine screen so I feel safe that you're going to counseling, you're going to 12 steps, you're doing this, which this is rebuilding not just the person, but I love the way, one of the things that really caught me about him is he said people have an addiction to a drug, and now they have almost an addiction to recovery, finding the rewards in life, right? But we need this for everyone. And we're trying to do contingency management in the Humani program as well in our faith-based churches. And it's working because we're using funding cards, right? So things along that. But we want to expand this. Absolutely.
So if your interest is to expand it as quickly and as wide as possible, and you want Medicaid part of that,
Yes, they have it.
which would be more, which would make it happen sooner? A waiver application or having it be a requirement within the MCO RFP to have them enroll their patients.
So we went through the route of Medicaid for the
Yeah.
1115 waiver because we saw that it went through. We're still gonna need general revenue to match the CMS third
Right,
wave. So we're gonna
but you
need
wouldn't need a matching if you asked insurers
in part of the
part of
RFP, and that would go to
participating
Medicaid.
in the RFP to be required to.
That's a really smart idea. That's actually how West Virginia did it.
Thank you.
Any final questions before Linda wraps us up?
Yep. All right, so now we're gonna go to the fun part, because this is how your money has been spent. And I want just really quick, when we're doing RFPs, there's a process. And that process is what we have in mind to do and what we actually want to make sure that gets done. And I just want you to see that the Department of Behavioral Health really does its due diligence. That when we write an RFP and everybody agrees that we're gonna do something, that is actually implemented the way that it was written, which is a big important thing, because it can come out 2 different ways. Next slide. I want to introduce you to some individuals that have expanded their bricks and mortar funding. Next slide. So Galilee Mission is going to start with Lynn Sierra and go, this is Lynn. So you expanded, you have 14 new beds and you named the new facility Brett's Place. Can you just stand for a second and tell us why you called it Brett's Place?
Sure, Brett Shovel and his gentleman who came through the gallery with him about 6 years ago. He did really, really well. He was back out into the community. And then about 3 years ago, he relapsed. So he got on the waiting list again to come back into the mission. And while he was on our waiting list, that's really good. His dad came to us and said, this can't happen. Everybody can't lose their son because they're on a waiting list someplace in the state of Rhode Island. So he, on top of, what we received here, he reached out to the Lions Club, to the South County community, and have been doing fundraisers every year to help us. In addition to this, we're looking at the treatment, we're looking at, so Brett is the gentleman who passed. His dad has been really instrumental in helping us move forward to continue this, beds.
Lynn is the CEO of Galilee Mission. It's in there again, so if you haven't heard about it, it's a marvelous program. Thank you, Lynn. Thank you, Mike. And Mike Sorrente also. So this is some of the pictures of the new facility. Next picture. So with that said, I just wanted to just close with, Lynn is also doing graded funding, right? Fundraising. It's not just your money, so it's maximizing your funds to get the most out of your dollars. Next is Zinnia, and Christy is here, and if you have any questions for her, Christy had, one of our larger facilities used to be Phoenix House. Now it's Zinnia has detox, residential, partial hospitalization, and they are doing partial hospitalization with recovery house. They have the full continuum of treatment. They're adding 30 beautiful new beds. Next picture. There's 23 detox, 16 females. That's where we gained more female beds when these been closed. 39 male beds. Just a beautiful facility out in Exeter around. They used to be on the old lad school grounds. Christy's here to answer any questions if we have them later. And next is Bridgemore, and we've got Megan here. This is in process. It will be 14 new beds. And they, if you're familiar with Bridgemore, it's been around for how many years, Megan?
I think we're incorporated, I'm not sure.
1975. So your foundational, great program from then adding and expanding. We're looking to up to 14 more beds. So if you add them up, it's 14 here. It's 30 there. It's another 14 there. Ad Care had a fire. We lost 20 beds. Your insurance just billed back 20 more. We're getting on our feet. Thank you very much for helping us expand treatment facilities. We still need to do a little bit more work around women's services and adolescent, but hopefully this has been helpful for you. Thank you.
Thank you so much, Linda. This is excellent. Kind of a whirlwind tour, but excellent tour, and hopefully beneficial to the committee and trying to get the whole thing through the wrong thing. Any final questions for Linda before we continue with our agenda, which would be public comment? So any final questions from the committee? Not seeing any. Let me open up for public comment at this time based on the presentation. Before we wrap up our agenda, and we'll have a few minutes for public comment again. Yes, could you state your name and if there was an organization, the organization, and we'll ask, I'll check the chat, but we'll ask for the public comment to be limited to 2 minutes. Welcome.
My name is Phyllis Serrano. I work with the House of Food, but I'm also a certified here every year, so that's in Rhode Island. I wanted to know, I heard a lot of comments about like extra bed and like housing, but like I don't see a lot for LGBT or the combined. Like we're running across right now where we have youth or under 24, under 24, where we don't have the beds for them, but it's men or women. So if we have a non-binary person or a transgender person, we have no replacements. And like, I recently just worked with someone outside of work hours, just to get into the same dress, which is up there, really interesting about them. But getting them into there, it's still a wait process. Like there's no guarantee on like what the next steps are for these people. And so like when you say Lynn about Brett, like that's what we're running into for our LGBTQIA plus community, where we have people that can identify with one or the other, but because of the liability that comes with having a woman that identifies as a man or presents masculine but has a female part, because they're genuinely asking questions like, have you been through a sex change? What can it tell you? Do you have, comfortable? So like, I don't see a lot of that when we talk about when I tell you, like, is there any kind of conversation happening around that?
Thank you for raising that issue. Linda, I wonder if you can speak to that.
Sure, I can. I'm actually gonna have Christy speak to this, because this is the conversation that we're having. So if somebody calls you Christy and, they're binary and they want to get treatment, what is the response?
So we are 99% Medicaid facility. So our response is never no. So we have a small confidential screening process that they go through, and we ask them where they're comfortable, how we have an opportunity to segregate smaller rooms if they're comfortable. We can split off the men and women to where we can make a safe area for them. We have not denied anybody, and we've had actually great success with LGBTQ community coming through, and then also being able to set them down, continue them in their recovery and PhD program with supportive housing, the peers that they've gotten comfortable with, starting at detox all the way through to say like a 4-month program. So they're they've grown that companionship, they've grown that community for themselves, and it's that longer continuum of care and just not saying no, giving them the option that we always make sure that we're available to their comfort level and what they prefer, and we will honor that since we would want that. Yeah.
So like I had the person in question, they were asking, and because they were just trying to have all they were not, so that was really.
So they would do a peak, yes, so they're like a whole.
And it's not, as providers, like, we're not provide our whole business, like, we do, don't want to do this here at all, I don't want to. But if someone other than at 4 o'clock, we shower at 12 o'clock, right before it's filling up at one of our locations, and then for me personally at a gas station after hours, I can stay there for 9 o'clock, and there's no other than going home.
So first of all, I'm just making perfect.
I understand.
We've got a long way to go, but part of PH is set up to bring somebody there, they can stay there for 23 hours, and they can stay there while we work out the particular. So they're not gonna go this level, they can find another level. So using 988, people can all get that information. Do we need more services for young adults that specialize? Absolutely. Yeah, I spoke earlier to me about some services. My goal, my future, if you want to see me retire, give me treatment on demand. Where people call and they get that bed right away. We're getting there. But the goal is to get to the place where you call and get the treatment that you need right away. And it's crazy value. But thank you for what you do. And
Thank
please do things like that. It's nice to have a thing from the app and stuff. Sometimes when you don't have a degree or you don't have a title that's big up there, or that kind of goes, so our listeners are very, I know. You need to join the Wednesday morning call, so we talk about barriers. And if they're running into one, you'll have everybody here at that.
Thank you for raising that concern. Kathy?
I just want to respond a little bit, to add a little bit to that. I know that, your organization is clear to continue with care, because it sounds like you're talking about two things. You're talking about treatment, and you're also talking about, issues with housing itself, like recovery housing also prevents supportive housing. So if you know, Sarah, your supervisor goes, but if we wanted to also do that, that means on the first Thursday of the month, and maybe should have meetings. And I'm sure you know this, but I'm just saying it out loud because I want to. I don't do the outreach. I don't know if you're saying, but I think I don't get to, I don't get to put into a lot of things before my not for the 9 days. So like, I just wanted to know that she's talking about housing as well, because that's also a barrier that we hear in the continuum here.
I thought I saw another hand. Linda?
Bonnie really did throw me with that award thing. I'm sorry, I skipped a couple of things I needed to say. One of the things that is really good, one of the things that is really important about opioid treatment programs, DEA registered, SAMHSA approved, BHDDH licensed, Rhode Island Department of Health licensed, and many of us are in great care. We have 2,262 standards that we have to respond to. 2,262. Now, only a little over 300 of those are BHDDH, and then SCAMS of 1662. But the reality is it covers every aspect of what we do, from brick and mortar to the social determinants of care work, social service suite. It's like health homes. It's a tremendous, for those of you that have ever worked in a licensed entity, 2,262 is a lot. We just spent $63,000 just to have one survey by one organization from Samson. $63,000. I just, number one, I always go back to the money because it's usually the barrier for anything. But the other piece is all of these over 2,000 requirements, regulations, standards, whatever they might happen to be called, really cause us to be top notch. And that's what I was speaking to, because my hope in speaking with you was to really address the mythology that is out there about opioid treatment programs, because we do it. I mean, it's a, you know, this is a form of overregulation and under compensation, our form of state. We know that, but this also shows that we really do have high quality requirements. And the other piece about the adolescent treatment programming, we used to have adolescent and young adult treatment programming. Kodak alone in Newport, we had at one point we had 32 adolescents in an adolescent treatment program. And you know why we don't have it anymore? Funding went away. You know, and we had over 50 young people in our program in Honey Canal. And but we had there's no money. There's just no money. And so I'm very happy. So I'm excited. I think adolescent and young adult treatment is going to be great. Thank you all very much.
Thank you, Linda. Gianna, I can't open the chat back up. I don't know how to do it. But maybe you can just from there, can you tell me if there are comments in the chat? Sure. I'm sorry, I can't hear you.
We're hearing that we can't hear the comment, they can't hear the public comment.
Okay.
So that was one.
But I think the main thing is, there's a couple of comments that were in here, but that was during the presentation.
Okay. Thank you both. Let me go back to the PowerPoint. While I pull this up, Dr. Chan, let me invite you up. We're moving into the update section of our agenda now. And Dr. Chan is kind enough to introduce his colleague from the health department. I was still November and that you introduce his.
Wonderful, thank you. So the reason for this current presentation is, last meeting, we had a couple questions about data and what some of the funding was used for data. And we just wanted the Department of Health, and Dr. Howell, you can come on up. Wanted to give a quick 5-minute presentation about some of the data that we're collecting at the Department of Health. And just as we think about this on a broad level, right? If we think about how we're addressing the opioid epidemic, I mean, there's so many people behind the scenes working to look at these metrics and stuff. So Dr. Ben Howell is the team lead for our substance use epi program. He's one of the people that really does all the hard work and makes people like me look good. So thank you, Dr. Howell. But he's going to chat for a few minutes about some of the data that we collect, kind of the work that goes behind that. I think you had some slides.
Thank you very much for the introduction, Dr. Chan. And I timed it and I can get it done in 5 minutes and 30 seconds, so I'll be very brief. I was told to overview the opioid surveillance data in the state of Rhode Island, how the money has been spent for the settlement, and why it's taking so long to get beta cases closed. So I'll be very brief. Next slide. So just a quick overview, and a lot of these slides are just here for resources. The substance use epi team at the Rhode Island Department of Health is composed of 8 epidemiologists and 1 mapping specialist. And we are funded, with the exception of the state, the marijuana epidemiology position, entirely based on CDC or NIH grants, directly or through Brown University. Next slide. Overall, the substance use epi program manages 9 unique data sets that guide the Rhode Island Department of Health's response to the opioid epidemic. This includes all data on fatal overdoses, all data on non-fatal overdoses in Rhode Island. Next slide, please. All data from the prescription drug monitoring program for all controlled substances that are dispensed to Rhode Island residents. All naloxone distribution in the state, including all community, pharmacy, and hospital dispensed naloxone, and the harm reduction surveillance system. Next slide, please. So we published all of this data on our drug overdose surveillance data hub, and we routinely update this. This is also the source for where most of the data on prevent overdose RI comes from. It's pulled directly from this hub for all of those topic areas. Next slide, please. We also present this at a lot of different meetings. I won't go into detail, but on average, our team members present roughly 5 times per week to guide people's intervention activities. Next slide, please. We also use this data to identify spikes that are occurring in the community for overdose activity and guide prevention work and try to make that as quickly as possible to address spikes in non-fatal overdoses. Next slide, please. Okay. So the $620,000 in fiscal year 23 and 24 that was allocated for data, I just wanted to go over it really quickly because I know there's some questions. My program specifically got $200,000, and I'll go to that in a second. $150,000 of that went to the drug overdose prevention program, and that was to hire a overdose fatality review coordinator position. And this was basically someone to run the overdose fatality review team. That person was just hired in May of 2023, and they've actually launched a lot of new changes. They've been nationally recognized, and now they're mentoring other states for how to do fatality reviews for overdose and how to implement the recommendations. So that's all with settlement funds. The laboratory received $100,000 for testing materials. In July of last year, new regulation passed for all non-fatal overdoses. Samples were sent to the state lab so we can test them to figure out why people are having non-fatal overdoses, but the lab didn't have any money to test or to buy the testing equipment. So that was spent on that. And then $170,000 was spent by the medical examiner office because of the increased number of fatal overdoses around to help pay for the contractors that do the work. Currently, there's only 1 full-time medical examiner in the state of Rhode Island, and the rest are contractors that work anywhere from 2 to 5 days per month. And okay, next slide. So for my team particularly, we are funded for 2 activities. The first was to create a new surveillance system that would allow us to monitor non-fatal overdoses in near real time. And that actually launched this October after nearly a year of work. This allows us to respond to overdose spikes or contamination in the drug supply even quicker. So this is updated every day. So this data is a little old because I pulled the screenshot yesterday. In this orange column here, we have the number of overdoses that occurred in the last 7 days in Rhode Island, and then what would be required to have an overdose spike alert, which we would consider concerning, and then direct prevention activities. In the absence of any spikes occurring that day, we also provide the burden of non-fatal overdoses in different regions of the state, comparing them to the overall rate. So we know communities that are disproportionately impacted, so we can guide our prevention and street outreach to those communities.
How is the threshold established? I was looking at this before and I didn't know.
Yeah, so it's currently just based on, how data is distributed is kind of like a bell curve, and it basically has to be 3 standard deviations over what it has been historically, which would let us know that it's a significant difference and it's something worth responding. If we set the threshold too low, they would basically be going out every day for some communities, and then you kind of get burnout. So we wanted it high enough so we would detect a real spike. Low enough so we would detect a real spike, but also high enough that it wouldn't be fatiguing our reduction by sending alerts every day.
So it's historical data, it's like an average or.
The last 180 days. Yep. Exactly. And then I just have one more slide on this. The other thing our program was given $50,000 to do was to create a heat map dashboard. And basically on our website right now, we have a number of maps that we publish every quarter showing overdose burden for non-fatal and fatal overdoses in different communities. But these are generally only updated every 3 months. The new dashboard would allow an individual to log in and they could create a custom map. So if I was a harm reduction worker in Cranston, I wanted to go out tomorrow, I could log in, make a map of all overdoses in the last 3 weeks in Cranston, then use that map to guide where I wanted to do outreach or put communication messages. And the last thing I want to say, because we were grant funded, these last 2 activities weren't things that we were allowed to do with the funds that we received. So that's why this funding was helpful to allow us to do these 2 different initiatives. And this one should get launched in January, hopefully. And then I just have 2 more slides. So then I was asked to briefly talk about how complicated it is to close a fatal overdose case and why the delay is so long. So in Rhode Island, all fatal overdoses are determined, this final thing here, by the medical examiner. And as I mentioned, there's 1 full-time medical examiner and then a number of part-time. And I think some of the positions, there's at least 3 medical examiner positions open right now on the RIDA website. So in order to make the determination of a fatal overdose, there's a number of different data points that come in. First, there's a scene investigator who actually goes out to where the individual had overdosed to collect information. Then the medical examiner performs the autopsy. They pull data from police reports, all available medical records from healthcare personnel, and then samples from the autopsy are sent to the state laboratory for toxicology testing. And so if any of these things are delayed, then it can delay the case determination. So if the lab has a 6-month backlog, then there's 6 months behind, or if there's not enough medical examiners to analyze all this data, then it gets really behind. Next slide. This is my last one. So.
You're great, you're doing great.
Yeah. After a case is determined, it then goes to the fatal epidemiologist on our team who does a quality control check. And then if everything looks good, our website's updated every week with the new fatal counts. After that, the fatal epidemiologist, if it looks good, sends it to abstractors at the health department to pull all the medical records that they can find on that individual. And then they spend roughly 3 to 5 hours per case inputting over 100 variables and trying to get different pieces about that overdose. So like, was there a bystander present? Was naloxone administered? Who gave it? Greater detail on the toxicology report. And then that's sent back to our fatal epidemiologist, and then that's a separate page on our website that's updated with more in-depth information. But just a 30-second overview of how all the different players involved to just close a single case. Okay, that's it. Hopefully that's 5 minutes.
Questions for Ben?
No, thank you, Dr. Hallowell. And I think I just wanted you to everyone here to hear that, because sometimes we throw up that one beautiful graph of fatal overdoses. But the money and the funding from OSAC contributes to some of these data analyses, and it is really complicated. And I didn't trust myself to explain this, why I asked Dr. Hallowell to join us. But there's a huge team behind the scenes that's synthesizing this, lots of different sources, so it is complicated. So we don't need a lot of money, but we definitely need some money to keep this work flowing. And this to me also, right, is how we're going to judge what we're doing, right? So I think it's important to hear from the programs and hear some program specific outcomes. But at the end of the day, we want to see the statewide, whether it be fatalities or whatever outcome, those are what we want to see decrease. And it's this data that Dr. Howell is collecting that's so important to really measure that. So thank you, Dr. Howell, for all your work.
Hey, can you go to the slide right before this one? When you talk about the complexity of closing the case, is there a certain duration? Like, what's the historical average for closing the case? What is it today?
Historically, it was about 90 days. I think that's what they're legislatively mandated to close a case in. Currently, we still have open cases from January, so about 10 months now. It's supposed to be less than three months. So hopefully we're able to hire medical examiners. And then the toxicology lab was understaffed. They just reached full staff capacity. So hopefully they'll be able to tweak their backlog and start to speed it up. But ideally, it would be 90 days. So
It sounds like it's mostly staff.
yes.
For you, Dr. Chen, the data that's coming in, how quickly is it pushed out when it's, why does that it gets pushed out? You know what I mean? If you know there's a spike or an increase happening in socket, does the data stay in your silo and not get pushed out until it's all compiled by the end of the week or so? Or is it pushed out?
So I would say that we do the best we can. I think that Dr. Howell's team, and feel free to chime in, is now doing the daily spike reports. It was weekly, but I think the point was, if it comes out on Wednesday and then there's a spike on Thursday, we wouldn't know until next Wednesday, which is less than ideal. So the daily spike reports is something that we've highlighted. For some of this, because it's so complicated, and you can see it relies on a lot of external stakeholders. Sometimes it just takes months to kind of get those final answers.
I can understand that.
Yes.
Just worry about it. The collected data, you can see something happening.
You're right.
It's not being pushed out because you see it and I don't, but we don't.
We push it all out. We try to be as transparent as possible.
Yeah.
I'll say on any given day of the week, I get an email with a spike alert for different communities, and towns across Rhode Island, and any person, I'm not special, any person can sign up for those.
Okay, I mean, but there is a process. for it.
Yeah.
Yeah.
Were you? that what you were asking?
No, I was just saying, for non-fatal now, that was the case, because we only analyzed the system, we would analyze it weekly, so it could be a while before, but now because we update it every day, it's only a 24-hour delay, so if there was a spike in Woonsocket yesterday, if you went on the website today, you would see it in the case counts.
How impactful would it be if you were able to fill those three medical examiners?
I think it'd be incredibly helpful. I think that's been a constant struggle.
So has there been any discussion on what the pay rate would need to be to fill those versus what the pay rate is?
There has, we have it benchmarked.
And would that be part of a budget recommendation that proposed pay rate be used?
That I would have to get back to you.
Okay.
Should be.
I'm going way out of my lane on this, but I'm gonna add to Dr. Chen's response. My understanding, outside of my lane response, understanding as an observer, is that we did historically underpay. That pay rate has been increased. There is nationally a challenge
I know,
filling medical
I know.
examiner roles. So we're competitive now with pay, but still filling.
Okay.
The question I had, how did you come up with the regions? I get the daily alerts too. I'm just curious, how did you come up with the regions?
Yeah, so.
Just by serendipity?
So what we tried to do was any region that was high burden to pull it out for its own region. And then regions that seem to trend together or have similar patterns grouped together. So we basically used data to see how if they were behaving similar. And then we worked with harm reduction agencies to say, when you're doing outreach to an area, which towns do you go? And how would you like the data grouped together? And we tried to, any high burden area, we tried to separate out. So the most impacted towns or most impacted regions should be their own region or so. And then generally the lower burden towns have the larger groupings together. And I should say too, on the back end, while this is grouped, each day we do look at the rate in every single town individually. So if one town had an anomaly, we could also flag that outside of the system.
Does that include children?
Yes. This is all non-fatal overdoses.
Thank you.
It might be more to the chief, but is law enforcement getting these
Yes.
these alerts also?
So either through the fusion center or just how the daily spike alerts go up. Yeah, I have, and the question I asked dovetails what Dee was saying too, is Region 9 and Region 11 is huge. But that, in the developing regions, you have the city of Newport, then you have like all of Quinnipiac Island and East Bay, and Region 11 is his region. Narragansett, some Kingston, something, there's some. It just seems very big, those regions, that's all I'm saying, but if you're seeing low numbers, that's fine.
And I think too, you know, like for Region 9, this is a relatively large region, 10 overdoses would be considered a huge event and a spike. Versus that is a very common number for just the city of Providence to have 15 to 20 in a given 7-day period is the daily.
But during the summer, I don't want to believe it, during the summertime,
It does.
Region 9 goes up.
Mhm.
And I just want to make sure and 11 was up too, just fine.
Yeah, but I'm wondering whether, like, it's fine to do this, but I'm wondering if you can kind of drill down more precisely geographically.
Yeah.
It could assist law enforcement in figuring out perhaps an area where the distribution is occurring that is likely connected to the overdoses.
Yeah.
Right?
So we may be getting a little outside of our scope and thread of the conversation now, and I'm only gonna bring it up because we are also running. Noted.
Dr. Howell, I would note that actually, that is a good idea. I don't know if we could disseminate that to like everyone, some of it may be small number on PHI, but maybe to stakeholders right in those places, more of a targeted spike alert or something.
Okay, not seeing any more questions from the committee. We have a couple of announcements and then I'm gonna do public comment and close the meeting. And really just a couple of announcements. Kathy's not presenting any updates from the Governor's Overdose Task Force today, but we are asking that you go to the Governor's Overdose Task Force page and, you know, look at past meetings, look at updates, because of course there's a lot of activity constantly happening through the task force as well. And I'm gonna remind it one more time, November 30th is our rescheduled next meeting. I look forward to seeing everyone on the 30th. And we will not be meeting in December. At the November meeting, we have several topics to queue up, including, as Dr. Marshall brought up, we'll revisit our FY25 funding recommendations. We'll chat about evaluation, and we will, at that time, talk a little bit about our terms and membership on this committee, because believe it or not, time is fast, and we're gonna start to have that rotation of terms coming up. So those are topics for November, later in November. Open it up now for public comment again. Gianna, I'm gonna ask you, Kathy, if y'all can help me with questions from the chat first.
I'd asked, folks, I don't know, if you can hear me on the chat or if you can hear, I said, you know, unmute and or raise your hand. For those that are in this room, it would probably be easier to go into the chat, just because they were.
Are there some in the chat that you can read out to us?
Yeah, I do.
I see one here. Question was, are there facilities that are focused on LGBTQ plus age group of 18 to 24? This is.
That was the answer.
Okay.
So, it was during the presentations.
Okay.
Monica asked, how is dynamic care useful for stimulant users who are not already part of the MAT's treatment system?
And I think Dennis asked a very similar question, so we'll address that.
I don't know.
If the intention for the funds of contingency management is a racial equity effort, what is the program doing specifically to recruit folks of color? Also, can you give us more detail on how patients can get enrolled in the program besides the individual calling themselves?
So we heard a little bit about that from the presenters and Linda and the Imani Project, and trying to diversify the audiences in them to get the message out about the program. And it sounds like also providers can refer patients. I don't want to speak for, I'm a little bit doing for expediency, but they'll correct me if I misstate it.
No, I would think the OTPs right now are the way that they sign up for the opiate treatment programs, but they have an opiate use disorder with a stimulant. That's this pilot program right now. We're looking to expand it, but at this point it's for the OTPs, and they can get information by calling any of the 5 that are on the list.
Thank you.
There was a question about whether, the contingency management was only for adults. Is it for adolescents as well?
So the program actually has worked with patients as young as 13 years old. And I guess the referrals depends on, you know, the age range in the treatment programs that are signed up for the pilot. I actually don't know the age range.
18 and over, for example.
The pilot is 18.
The pilot.
I think we've gotten them all from the chat. Any other public comments in the room?
If you just, one final thing, so the question earlier was about the data, and every Wednesday, as I said earlier, Rido comes and they give us all the data on the recent overdoses. We hear from harm reduction on the streets about overdoses, we hear from hope initiatives, and then we put out an immediate call to action plan. And 2 adolescents, 15 and 17, that overdosed this week. From that plan, we asked them all schools to be aware that there was some purple powder that people were using, consistent patterns, things along the line. So yes, we do give the information, and there is a plan for action for implementation.
In addition to that, I just want to add this to what Linda said, the same, there's also, as part of the, ISS, project at the Department of Health, there's also a peers meeting, that's what we call it. It's actually the, funded, which this body has also expanded those funded programs from OD2A, the Overdose Data Action from CDC, which is, very much partnered with the ISS. I'm sorry to speak for you, Ben, and I'm sorry to speak for Rido, if you're in the audience. And so they meet every Wednesday and they look deeper into that data as well, and they actually send out PHPDH outreach workers and as well as the Rido funded outreach workers, which is in part funded by this community.
And Dr. Gasper?
I have a question for Ben. Is it possible in your, in the search for medical records for overdoses to detect if the patient is in treatment for some disorder? And is there any feedback with to providers? Can we do that ourselves? Is that, connection feasible?
Yes, we do know for all overdoses that they're in treatment at the time of that, the types of treatment that they're in. I am looking at the feedback that the data that was provided.
I mean, it seems like that would be a help.
I don't know about there being looked back to the providers, but there's also an overdose data council where all of the HGDH, the Department of Health, and others, even the Department of Labor and Training, we all get together and we kind of look at data, and we look at it as a whole. So for this week, yes, and then we also have Prevent Overdose RI, which is being updated. I think Brandon left, it's under Brown University as a contract, and some data is actually captured and uploaded in there. But right now, it's not as up to date as we want it to be. So we're in the process of revamping that and updating that and the metrics.
Yeah, because that kind of push notification can help programs have morbidity reviews, morbidity and mortality reviews, which is standard practice throughout, you know, medicine specialties. It would be very valuable, you know, for providers and for hospitals.
And Linda Mahoney. The green challenge to answer the question in 30 seconds.
Go for it.
Can you speak to reimbursement for substance use treatment services in Rhode Island versus other states in the context of sustainability?
Yes, I can, and I've given all the data to the director as well as to Secretary Sherez. We have looked at Massachusetts, Connecticut, and other states, and we were underrated on the funds that we were getting. So yes, we did give that to all OPEC and everyone else that asked for it. I can give it to you.
Thank you. Well done. Well done. Linda Hurley, last word.
Okay, we're the 4th lowest Medicaid rate in the country. Of any states that have Medicaid, we are the 4th lowest. And as of 3 weeks ago, we have the 7th highest overdose rate per capita. So those are the data points that we all need to figure out as we're trying to do our work. And that's it. Thank you.
Thank you. Okay, thank you. Okay.
Terry, just one comment. Earlier, it was this year, end of last year, we heard from the Ethics Commission about supposedly we're supposed to file financial disclosure. They were going to be mailed. Never received it, so I followed up. They said, we do not have to file. So just so the members know, you may have to file because of other roles you have, but not.
Yeah, we will.
Thank you. Thank you for the update. Thanks, Jeff. With that, I'm gonna conclude today's meeting. Thank you all for the extra few minutes, and thank you for all the fabulous presentations and the presenters who came from near and far. Thank you.
Yeah, we'll do that.
Oh, thank you. I'm gonna.
We'll do that financial colonoscopy once a year. GI doctor.
Oh, yeah, I think that